for joining us for a special edition of our organizational town hall this week. This week, we wanted to take the opportunity to talk to you about our community engagement that we have planned for the end of August, and also share with you a draft presentation for your feedback as well. So we have community engagement sessions scheduled for August 26th in Durham at 6 p.m. at the Community Center, and August 27th in Chesley at 6 p.m. at the Chesley Community Center. There'll be 2 sessions, and all 4 sites are invited to the 2 sessions. During that time, we would really like to hear from our communities around the future of services for South Bruce Grey Health Center, and also complete a survey process with all of our communities to find out what their thoughts are around specific questions, hours of operations, the healthcare delivery we are currently doing, and what we could potentially consider for the future. So along with the engagement sessions, we will also be providing a survey opportunity. The survey will be located on our website, but will also be available in different areas of all of our communities, paper copies, which we are currently finalizing on the logistics of those. So over the last 2 weeks, we have been meeting with stakeholders and small groups of stakeholders and showing them a draft slide deck. And after the presentation, they have been providing us with feedback into certain areas that we should think about or consider for the discussion, or also telling us what they feel is not really relevant. So we're hoping today that we would be able to have some feedback from our staff as well. Once I've completed the presentation, we'll have a question and answer period, and we'll open up the floor. And certainly feel free to share your comments as well. There will be 3 phases to the engagement. The first phase is August 26th and 27th, and then an open survey period for an additional 2 weeks. And during that time, we will collect all of the input we've heard from our communities. Then we will summarize our findings and provide an online report, which will be available on our website, but we will also plan to have another engagement session with our communities to share the findings that we have heard. Following that, we'll have a 3rd phase, which will take us to our next steps. We don't have any dates at this time for the 2nd and 3rd phases, but more information will be shared as it becomes available. So I think we'll go ahead and get started. And remember, this is a draft presentation. We are taking some components of this presentation forward with our engagement session in the town halls, but there will be changes. So this is not the slide deck in its entirety that will be shown on the 26th and 27th, but please feel free to reflect on what we're showing you and provide us with some feedback. So today it's a reminder that South Bruce Grey Health Center remains committed to all 4 sites. And today's conversation is about discussing what services could be delivered at each site to best serve all communities across South Bruce Grey Health Center with the resources that we have. The purpose of today's meeting is to provide an update on our current context, where we are today, and our challenges that we face, discuss future community engagement plans, provide you with an opportunity to gauge on the future of the organization, and answer any of your questions. So when we look at current context, or where we are today, we know that we are facing health, human resource, and staffing pressures, specifically with registered nurses and in some cases physicians. And it's becoming more difficult to adequately staff all of our sites. We've had to make temporary unscheduled service reductions in some of our emergency departments related to staffing. And we can see when we have a smaller site and we receive a sick call, we don't have the ability to absorb that and put a replacement in. Our staffing just does not allow it. So when we have our bigger sites with Walkerton and Kincardine, we have a little bit more ability to absorb that sick call with a larger group of staff and additional resources. Our human resource department continues to recruit and retain staff through innovative strategies and partnerships with Ontario Health and the Ministry of Health, and we've had some success with those programs. When we look specifically at the Durham site, from April of 2023 to March 31st of 2024, that's considered our fiscal year, the Durham site experienced 61 unplanned short emergency department closures, and they were all related to staffing. So these were not planned closures. And during that same time period, the RNs at the Durham site worked a total of 3,119 hours of overtime. Considering the size of Durham, that's an incredible amount of overtime and certainly speaks to the dedication of the staff at that site. We knew that the registered nursing vacancies were expected to reach over 40% this summer, and that was up from 35% last summer. And we saw the significant number of closures we had related to 35% vacancy rate. We continue to rely on agency staff, not just in Durham, but across all 4 of our sites. When we look at Chesley from the same time period, April 1 to March 31st of 24, Chesley experienced 45 unplanned short notice emergency department closures related to staffing. During the same time period, the RNs at the Chesley site worked a total of 1,547 hours of overtime. Again, a tremendous amount of overtime and speaks directly to their commitment to the organization. When we look at Walkerton and Kincardine, they are able to have a bit more stability just related to size. They do continue to provide 24/7 emergency department care. Newly graduated nurses and physicians, and we've heard this directly from staff, really want to work at a bigger and busier site. They want to be part of clinical scenarios and have that exposure and learn. They want to be busy and see lots of clinical aspects of care. And that's a bit more challenging in a smaller site with lower volumes. Next slide. So when we talk about emergency department volumes, and this slide might be hard for you to see, but you can see the 4 green bars. Those are the sites of South Bruce Grey Health Centre. So when we look at the far right, that's the Chesley site. And these are emergency department volumes from 21-22. So Chesley had over 4,000 visits during that time period. And yes, they did have reduction of hours during that time. The Durham site was 24/7 and they had over 7,000 visits. We move over to Walkerton, they had over 9,000 visits. We move down to Kincardine and they had over 13,000, and we know that's significantly higher with the recent data that we've seen. And then if we look to the left, this is Hanover, over 17,000 visits. So Chesley and Durham have some of the lowest volumes in the Southwest region. So when we look at the time of day that patients are going to access care, and this is across all 4 of our sites, it's interesting that the busiest times are from 7 a.m. to 5 p.m., and that's consistent across all 4 sites. This may be surprising to some people, but it can probably directly be related to the number of unattached patients we do have in our area. And if patients do have a family doctor, it is difficult sometimes to get in a timely manner as well. So that could play a part of the time as well. But when we look at overnight, we don't have a lot of volume. Next slide. So when we talk about the emergency department acuity scale, and many of you on this call are quite familiar with CTAS scores, but there are 5 levels to a CTAS score. Level 1 is resuscitation, level 2 is emergent, level 3 is urgent, level 4 is less urgent, and level 5 is non-urgent. When you're running an emergency department, you have to staff for the most severe case that could come through the door. So that's the resuscitation case. So that requires a minimum of 3 registered nursing staff plus a physician to be available for that emergency that comes through the door. So when we talk about emergency department visits and acuity levels, when we look at Durham, and this time period is from June of 2022 to June of 2024. Durham sees on average 20 visits per day. And somebody might say, well, I know it's more than that. You're right, it could be more than that on some days, but on average, it's 20 visits a day. Less than 10% of these visits truly require emergency services. So less than 10% actually are CTAS 1s or CTAS 2. So that's less than one visit a day. Most visits to the Durham ED might be able to be managed by a different model of care, whether it's urgent care or through a primary care nurse practitioner model. So you can see on this graph that 90% of the ED visits in Durham are CTAS 3s, 4s, or 5s, and 10% require actual emergency services. So the dark blue are CTAS level 5s, the green are less urgent, the yellow is urgent, the orange is emergent, and the red is resuscitation. When we look at Chesley Emergency Department visits, the Chesley ED sees less than 10 patient visits per day on average. Approximately 7% of these visits truly require emergency services, so they are scored CTAS 1 or 2. Again, the majority of Chesley ED could be managed by potentially a primary care model or urgent care. And this is the same time frame from June of 22 to June of 24. So very similar looking graph, but only it's not as tall because the volumes are lower. But again, the blue is non-urgent. The green is less urgent. The yellow is urgent. The orange is emergent. And CTAS 1 resuscitation is red. When we look at Kincardine and Walkerton emergency departments, they see slightly higher volumes of patients who truly require emergency services. And we also have not seen an increase in ED visits at Kincardine or Walkerton since reducing the hours of operation at Durham and Chesley. And this is no surprise probably to everyone on this call, just related directly to geography. So what does all this information tell us? Well, we know we have a critical staffing shortage, and it's not just South Bruce Grey, it's across the province. This is not just our organizational problem, it's a challenge for many organizations across the province, and we continue to rely on agency nurses to support the delivery of care. We know that Durham and Chesley experience some of the lowest ED volumes in the region, and that plays a part in making it challenging to recruit and retain staff. Historically, Chesley and Durham only see between 1 to 2 patients overnight. And we also know that a high volume of patients use all our sites for non-emergent reasons and perhaps could be cared for using another model. So that's our current context. When we think about opportunities for the future, what are they? So we continue to work with Ontario Health and the Ministry of Health and our health system partners, looking for ways to maintain and potentially enhance as many services possible for our communities. So you may say, you've just said we have a staffing shortage. How can we potentially enhance services? We have the ability to do that through partnerships with other hospitals for service needs that potentially community members are driving for outside of the region. We want to hear from our communities what services they feel that potentially we should look at because they're accessing them outside of our region. And it's something that we could bring to help stabilize and increase accessibility to our patients and families to receive the right care in the right place and at the right time. So when we talk about proximity to other hospitals, the South Bruce Grey Health Centre area is very unique when you look at the rest of the province. We have a lot of hospitals that are very close together. So if we're not providing emergency services, There's less than a 30-kilometer drive to the next closest hospital. And I know for some people that doesn't mean anything because if it's not in their community, that's what matters. But the reality is, when you have a true emergency, there is a hospital close by that is available to access care. When we look at the provincial nursing shortage, we know it's not going to end tomorrow. We know it's going to continue. And the reality is we need to change what we're doing to adapt to a new model to help support stabilization. So when we look at this graph, it shows us from 2022 to 2027. So the pink bar is the total nurses required in the system. The dotted line that you see, it might be hard to see, but the dotted line shows the gap, shows the actual shortage that is existing. The black line actually is the expansion of nursing enrollment that's planned over the next few years. The light blue line is the international registration, which we have not seen a lot of uptake in rural areas. And the darker blue is the natural growth that we anticipate over the next few years. So you can see just based on this information that it is going to take a little while before we actually have stabilized nursing volumes of staff. So when we look at opportunities, we need to look at all 4 of our sites and say, what strength does each site have and how can we build upon that? So when we look at Chesley has a very strong rehabilitation and restorative care program. They have 18 beds. The infrastructure itself is designed for that patient population. We have long-term care patients awaiting long-term care at the Chesley site. And it's designed to support that type of patient. You have community dining, you have a strong allied health resource as well. So it's a very strong component for Chesley. When we look at Durham, what do we know about Durham? Well, when we look at outpatient data, we know that a lot of outpatients access Durham for their x-rays, their ultrasounds, their BMD, and also the emergency department at this time, and the lab. So we know we have a strong outpatient component to Durham. Kincardine. Kincardine is one of our busiest sites. It is a growing community. It does have expanded diagnostics with CT and mammo, but it also will be the MRI site for the region as well. So that's their strength. When we look at Walkerton, Walkerton has the obstetrical program, and it's quite remarkable. On average, they do over 430 births a year. And to support that program, we have an after-hours surgical program that also provides surgeries, emergent surgeries when required as well, in partnerships with Hanover. So when we talk about access to care, we have an opportunity here to look at all of our sites and see how we can potentially expand our service or enhance the care in our region. We need to have the input of our communities. So we know what we're experiencing today, and what we're experiencing today is not really new. We've been in this challenge for many years now, but it's not getting any better. And you can see by that graph that I showed previously, it's going to take some time. So what can we envision for the future? Stabilized staffing, consistent, safe, and reliable access to care, what that looks like, less reliance on agency nurses and locum physicians, and potentially access to new specialized services. What is it patients are traveling for? Is it mental health? Is it cancer care? Is it specialized geriatrics? What is out there that potentially we could look at? So when we talk about next steps, we're going to collect all the feedback that we hear from our engagement sessions. We're going to look at the feedback we received for our online survey. Then we'll report all of our findings and share them. And we will also schedule another in-person community engagement session to share the information that we have learned. So we need the community input on our plans. So we're asking specific questions, and the questions aren't exact that the ones I'm showing you today, but they're along these lines. So what healthcare services that are not currently offered would you like to see in our community? If we cannot provide 24/7 emergency department service in Chesley and Durham, what hours of operation should we consider for urgent and emergency services? Are there any other partnerships that we should consider to support healthcare delivery in our community? Is there something we're overlooking? Are there challenges that you have experienced in accessing healthcare in our community? And we know what some of the answers will be, but we want to make sure we're not overlooking anything. What are the most common reasons you visit a South Bruce Grey Health Center site? Do you get your lab work done every 2 weeks? Do you not have a family doctor and you have to rely on the emergency department to receive your care? Why are you coming to our sites? When you think about great care and healthcare service, what does that mean to you? Everyone has a different definition. We want to hear what everyone's perspective is. And what aspect of healthcare service is most important to you? Is it the location, that it remains in your community? Is it that you don't have to wait to see a doctor? Or is it the quality of care? We want to hear what exactly is most important. So that ends the presentation. And as I mentioned, this is a draft presentation. It will not be the exact one that's shown in the engagement sessions. But we really want to hear from our staff, and we've heard from our stakeholders, and they've given us great feedback about potential considerations that we should include or discuss. So I'll pause there and I'll open up the floor. Feel free to either raise your hand or put a comment or a question in the chat box. I know it's a lot of information to receive at once. There's a question, has a walk-in clinic been considered? So that's something that we'll wait to hear from our community engagement sessions. And if that's something that the community is interested, then they should be bringing that forward. But we're really interested in what the community's thoughts are. So that may be something we hear. Just going to open the chat box here so I can read this better. Hanover has high volumes of ED visits. Is there data to reflect how many of those patients are actually South Bruce Grey Health Center patients? I don't have that data specifically. It's something that we would have to rely on from Hanover. And how would we tell that they're one of our patients? Is it by family doctor or is it by geography? So we'd have to think about how we would want to break that down. But it's something that we could look at. So it's a good question.
And also important to note that the data in that chart is from 2021-22. So prior to any service reductions in the Durham Emergency Department, and at that time, intermittent closures for Chesley. So that was some time ago, not recently.
Cardiovascular disease is the leading health condition among Grey and Bruce County residents with limited access to specialized care. Strengthening partnerships to enhance local services could be beneficial to our communities. Absolutely. And we may hear that as well. Why can't some of the less urgent patients from Hanover be considered to come to Durham or Chesley sites to help with their patient numbers and more urgent cases in Hanover District Hospital? That's another great question. That's something that we can consider for the future, but we have to have the feedback from our community. So thank you for that, because it's a great suggestion. Just a comment, I'm not sure I agree that CTAS-3s are not required to be seen in ERs. Those patients usually require same-day blood work, often imaging, and sometimes do end up being emergent cases. The typical abdo pain would be a CTAS-3 and could end up being a bowel obstruction, appendicitis, ectopic pregnancy, etc. These patients can't be managed in a family doctor's office. I just don't feel your number of patients needing the ER CTAS-1s and 2s is an accurate reflection of reality. And to Dr. Chittick's point, that CTAS-3 can evolve into something larger, absolutely. So there is some variability with that for sure, but they could start off being worked up in an urgent care potentially, and then being transferred for emergent follow-up if that was the case. But that is a very important factor to remember as well. So thank you for bringing that forward. What about scheduling an on-call RN for Chesley and Durham so we wouldn't be paying overtime if a sick call comes in? I'm not sure we have the staff to do that, but perhaps it's a consideration that we can take away as a suggestion. So thank you for that. What is the physician and nursing recruitment plan? So we continue to participate, as I mentioned in the slide deck, with supporting new grads with education and bringing them on to help retain them. Also, we continue with all of our innovative recruitment strategies that we have been doing, and we also work with other hospitals to see what they are doing as well to make sure that we're not missing anything. So we do continue with our recruitment plan, and HR does follow all of those strategies. When it talks about the physician recruitment plan, I can't speak directly to that. There is a physician recruitment committee for each area as well. So that's something that perhaps someone from the physician side of the house would be able to speak to. But I know they're actively recruiting. Well, I don't see, oh, there we go. Have we examined feedback from employees who have left South Bruce Grey Health Center to see what we can improve upon? So I know that there are exit interviews that are completed. That's correct. I'm looking down to Audrey and Lisa on the screen.
Thanks, Nancy. Can you hear? Sorry, we're just sharing the computer here this afternoon.
No problem.
Yeah, so we do track all of the exit interviews that are returned. For everyone who resigns, they are given the opportunity to either come in and meet in person, or do a virtual, or they can send in a paper-based exit interview, and we do track all of that information. And then we roll that information up into like an aggregate report and then report out on that. So we don't provide specific feedback because we do keep it confidential, but we do provide generalized information back to the management team.
Great. I won't have you go off on mute yet, Audrey, because there's another HR question here. How does South Bruce Grey Health Center sick time compare to other hospitals? Based on the amount of sick time being worked by nurses, clearly burnout can be expected. We need to do better to prevent this. So how do we compare to other hospitals and the OHA average, Audrey?
We're actually a little bit below the OHA average right now, Nancy. Not much, but just we're tracking a little bit below.
Okay, thank you. Is there incentives to keep physicians supporting our emergency departments in place? Yes, there are. Agency nurses are not the fix. Agreed. You mentioned the lack of primary care in our area as a reason for our numbers of CTAS 3 to 5 patients. How do we recruit more primary care? So it's not the number of CTAS 3 to 5 necessarily, but it's the time of day that I mentioned that perhaps could be a factor in why we're seeing the between 7 a.m. and 5 p.m. as the lack of primary care. So there are a demand for physicians, as everyone's well aware. And again, it's about recruitment. And there's many options for physicians out there today. So it's trying to find a physician who wants to work in rural healthcare, and certainly in the beautiful area of South Bruce Grey Health Center. Just to reply to your response to my comment, I think it's not whether or not they become CTAS 2s, it's that they need resources, lab imaging, etc. at CTAS 3 level that isn't available in family doctor's office. Noted, absolutely. But they would be in urgent care. Sorry for the mix up there. All these patients will and should be treated in an ER or yes, perhaps urgent care center. But if that doesn't end up happening, all these patients would need to be seen in another ER. Yes. Is there a plan to enable a nurse practitioner work in the ER department for? So that's again feedback that we would like to receive if people think that's an option. Most physicians that want to work in rural areas is because they can work both ED and inpatient medicine. Noted. ER to everyone. Oh, 3s and 5s. So department for 3s and 5s. Oh, that was the rest of the question. So yes, because we do know that Hanover has an NP in their emerge that does see their lower acuity patients to assist with volumes. That is a great point. Exit interviews. Have we looked at all the options for nursing to make working for South Bruce Grey Health Center desirable from a nursing HR perspective, i.e. flexible scheduling, or though for those that just want to work weekends, just emerge, etc. So I know that there's been lots of work done in the scheduling department. I'm not sure we have enough staff right now that we have that option of putting in desirable rotations. Maybe I'll pass that question off to somebody who works directly with the schedule.
I can try to answer. I know Michelle's not here today. Just as far as I know, we've been trying to do a lot of work with adding some more, we've added additional full-time positions, particularly for nursing, to try, because we have found that that's definitely been more desirable for particularly new hires coming into the organization and has helped attract more people. I know we have, obviously relatively recently from the scheduling project perspective looked at the pros and benefits between the dual sites and the dual department positions, and definitely working on finding that balance where we know it's important to have the single site positions, which are more preferable to people, as well as the some dual site positions, obviously from a scheduling perspective, to sustain our operations is helpful as well. So we have been trying to work to have the balance to ensure that those single site positions are available. The department ones, single department, is more challenging, just with particularly with our smaller sites, but all of our sites being relatively, not large hospitals. The ability to be able to move staff can be pretty important to keep services going at times. So that's why they typically are dual department, even if people predominantly work, more of their shifts in one of the departments. So again, open to if anybody wants to send in either to the patient care managers or Michelle or myself, if they have any specific ideas of what they think would be appealing, that we're happy to look at any other options. If there's things that we can see if they would work with our particular sites and how we need to staff each of them.
Thanks, Mandy. So how often are you using agency nurses in Walkerton and Kingarden? So I know they're being used. I can't speak to how often. If we had to just put an average, does anybody know?
Nancy, it's Kathy. I'm not sure I can give you an average, but I would say just using this week as an example, I'm using 1 to 4 agency nurses a day.
Okay. And how many times has an agency nurse been used in Durham when a Durham nurse has been moved to Chesley or Walkerton to fill shifts? Does anybody have that data on them now? No, I don't.
It's Krista. I don't have that data, but it's available in the schedule. Everyone can see that.
Oh, okay.
We could look to see how we could report that exact number. But it's on the schedule. The schedule is available to everyone, and it's updated and as up to date as possible at any given time.
Okay, thanks, Krista. So they can use the schedule for reference. Okay, well, we'll give it one more minute, and we're coming close to the end of our scheduled time. If nursing is the main cause to closures, perhaps there should be more engagement, such as this forum, so the nurses feel heard to express concerns and brainstorm solutions. There we go. It's a good takeaway for our management group as well. Happy to hear from our nurses and any ideas that they may have. At quick glance of the schedule, very few times an agency nurse has been used in Durham since June 3rd, and each of those times and Durham nurse was booked in either Walkerton or Chesley. Okay. Scheduling, great idea to get nursing feedback. My thought is you're better to have a nursing working only weekend shifts than not have that nurse at all, or just working Walkerton ER than have that nurse work for our corporation at all. It's a great point. Okay, so I really appreciate the feedback and the comments. It's information we need to take away so we can better engage our community and our staff. So thank you for that. Just because this session is ending now does not mean that your input is ending. So please feel free to send out an email to Megan Legg if you have any further comments or questions or thoughts or information you feel we should share more publicly in our presentation at our engagement sessions. We'd love to hear from you. So thank you very much for your time, and we truly appreciate your feedback, which is extremely valuable to us. So thanks everyone, and I hope you have a great rest of your day. Take care.